functions of the bladder, as you all know, what are the functions of the bladder? Storage and voiding at will, emptying the bladder at will. And how should the storage be? Storage be at a low pressure storage. How is the kidney destroyed? By two reasons. One is high pressure in the bladder and recurrent infections in the bladder. So low pressure storage and voiding at will, for which we need the detrusor, which is a smooth muscle controlled structure, and also the sphincter, which is a skeletal muscle controlled structure. We will look into the details. Next one. So when you call it is a bladder as neuropathic, when there is a loss of voluntary control over the initiation or voluntary control of the inhibition. Either situation is called as a neuropathic bladder due to various neurological disorders. You can name a lot by yourself. Next one. In the rehabilitation, what are the goals? The goals that you see are the preserve the renal function, because with the kidney is damaged, then there is nothing you can do. You can probably transplant and all those things. Other than that, you cannot retrieve that. So preserve renal function and ensure towards that, ensure a low pressure storage. Next one is, and provide continence, social continence. You have to neither leak through the bladder, or you have to be able to empty the bladder at will. So how we will do? First, we'll go a little bit about the innervation of the bladder. So one of the common questions we always ask: how does the bladder know? How does the brain know that the bladder is full? So for that, there are two essential fibers. One is the A delta fibers. It's a bladder, and the common, let's see. First is, we say A delta fibers. Let us say A delta. A delta means, Erlanger gas are divided into 1, 2, 3, 4 large fibers, quick fibers, but they are fibers which take the bladder volume changes through the dorsal rod. It will go to a nucleus here called the Gertz nucleus. This gives the instant changes of the volume. Continuous changes of the bladder volume are not reported to the brain. So brain need not know whether it is 35 ml, 40 ml, 45 ml, 43.5 and all, don't need to know. So this goes directly to the periaqueductal grey matter. Periaqueductal grey matter is where? In the midbrain. Periaqueductal grey matter. This goes directly, the fibers are from the neuron. The fibers goes to the periaqueductal grey matter. From the periaqueducal grey matter, but the periaqueducal grey matter also is interesting thing. That also doesn't communicate directly to the spinal cord directly. That talks into the pontine maturation center. It is, or you can say Barrington nucleus. From there it goes to the that also controls the. So this is one pathway. That, in other words, what we are saying is the changes in the bladder volume as it increases, it is not reported to the cortex. The cortex is not aware of all that. How much is there now? Now it comes to a critical volume. But let us say 300 volume ml, 400 ml, like that, and its distance. Bladder is distended. When the bladder is distended, what happens? Then the C fibers are activated. That is where the capsaicin sensitive receptors and all. C is activated, and that C fiber now goes into that. Neurons are activated, and those neurons are activated. From there, that cross into the midline and go up to the other side into the thalamus, PL of the thalamus, and from there to the somatosensory cortex. So now the brain now knows that things have come to a critical level and some action has to be taken. And from there it comes, when the cortex decides, then to the central maturation, cortical maturation center. From the cortical, you remember the pathway from the side of the brain, and the signals come to the pontine maturation center. and from there you get activating both the in the S234 area. What do you have? You have the two things. You have one neurons which are parasympathetic neurons. Then you have the somatic neurons, and then you have the other neurons of the on-off nucleus of on-off. These are the on-off nucleus is the nucleus that controls the sphincter. The medial part is for the bowel sphincter, and the lateral part is for the bladder sphincter, external sphincters. So now you have, so these from pituitary centers you get connection to the on-off nucleus as well as to the parasympathetic nucleus as well as to the detrusor. So detrusor contracts. When the detrusor contracts, the other has to relax. It's not so. Therefore, there will be inhibitor neuron in between. So this is the rough guideline. Now we will go into the detail of that. Then comes so you understood the pathway now. You know all these things. Hair delta fiber, constantly the stretch impulses to the dorsal horn, to the synapse in the Gertz nucleus there on the lateral part, and of the posterior horn, and from there it goes to the periaqueductal gray matter and not to the cortex. Whereas the C fibers goes to the dorsal column. They usually that C fiber is going to 1, 2, 5 and 8 layers of the Gertz nucleus, dorsal horn. From there it goes to the cortex. Now the efferent pathways, what are the efferent required? You require one for the detrusor, one for the smooth muscle sphincter, and one for the skeletal sphincter. These are things. So motor supply parasympathetic into S234, that is what we drew there, to the parasympathetic for the pelvic, through the pelvic nerve. The nerve is known as the pelvic nerve. That's how. Efferent is for. Then sympathetic supply. The sympathetic supply, as you know, comes from the thoraco-lumbar outflow, the lowermost part, T2 to L2. Then that comes out as hypogastric nerve and goes into detrusor. So sympathetic supply, it supplies the sphincter. I'll change. Okay, sphincter, and when it comes to a sphincter, it has got dual action. Detrusor, it relaxes. And the smooth muscle sphincter, it stimulates. So in the thoracolumbar flow means from T2 to L2, from the T2 to L2. T2 to L2, when you cut the spinal cord, what will you get? When you cut the spinal cord, you have got cells in the intermediolateral column. This intermediolateral column. They come out. How do they come out? They come out, these neurons will come out to the anterior root as the white rami communicant is with our code there. Comes out, gets into the paravertebral ganglia, and then to the paravertebral ganglia, the synapse and the postganglionic neuron come out and goes along the anterior root. So from the T2 to L2 level, this is the sympathetic fibers. They come out. They altogether come out as they're known as a hypogastric nerve. S234. You get the S234. If you cut here, cut there. S234. You cut there. You will get there's no sympathetic ganglion, but there is the ganglia cells for the sacral parasympathetic neurons. So that will be, and also the somatic nucleus. So here you get this from the sacral parasympathetic neurons. Sacral parasympathetic neurons, they will all come together and is known as the pelvic nerve, hypogastric nerve. And from the somatic nucleus, it all comes together, and that is known as the pudendal nerve. Pudendal, the word meaning pudendal means secret. So pudendal nerve. So we have got the hypogastric, which is the sympathetic, pelvic, which is the parasympathetic, and the pudendal, which is the somatic. So what is the interplay of all these things going to happen now? So the hypogastric which comes there, hypogastric comes from the yes, now that supplies both the detrusor as well as the smooth muscle sphincter. Smooth muscle sphincter. So it comes to the smooth muscle sphincter. What does it do? It stimulates the, it inhibits the detrusor and stimulates the smooth. This is a smooth muscle sphincter. This is a smooth sphincter. There is another skeletal muscle is coming now. That is which is under our voluntary control. This is the one that we are able to have control. We have to start the maturation, stop the maturation. All is from the skeletal sphincter. External sphincter. So otherwise known as the external sphincter. I never knew my handwriting was this bad. So then this is the smooth muscle, which is the internal sphincter. Otherwise is known as the internal sphincter. How does it do? How is it possible that the same nerve is able to stimulate one part and inhibit other part through the distribution of the receptors? Here it is the alpha receptors. Alpha receptors are stimulatory. Therefore, you get an increased tone and produce the closure of the neck. So they try to improve the storage. Is it not so? The alpha through A delta, through the pontine inhibition, through the sympathetic discharges, you are trying to close the internal sphincter. And here, because of the beta receptors, you get the relaxation, and therefore storage is permitted. Pelvic nerve comes, that is coming from the sacral parasympathetic nuclei, sympathetic nuclei. So the pelvic nerve comes that again from that, and that what does it do? It supplies the detrusor. It supplies, pelvic nerve supplies the detrusor. Supplies the detrusor. The mediator there is acetylcholine. Here it will be norepinephrine. It's not so. And then comes the skeletal supply. So skeletal muscle comes from that through the pudendal nerve that supplies the external skeletal muscle, stimulatory, and also the pelvic floor muscles. All pudendal nerve supplies most of the skeletal muscles of the perineum in the anterior as well as the posterior triangle. So this is the again the pathway in the lower end, how they are connected. So here you found the sympathetic nuclei. Here you have the parasympathetic cells. Here you have the somatic cells. And these are all going to be controlled from the higher centers. Now the brain has known that action has to be taken. Sensory fibers to the pelvic nerve, motor parasympathetic supply is 234 segment, and sympathetic supply T12L1, and the somatic supply is 234. So you can see the entire brain from one end to the other is involved in the process of maturation for the social reasons, or even before for the, you said that the maturation is the time when the person is vulnerable for the to be preyed upon and all that. So there's a lot of layers of control at the higher centers. Next one. So it's the autonomic reflex under the higher control. Next one. Higher centers we are going to talk about. One is the spinal maturation center, as we have talked about. There's 2, 3, 4 spinal segments. That is a good center which is being controlled from the higher centers. Next one is pontine maturation center. It's also known as the Barrington nucleus, and it has got a medial part as well as a lateral part. The medial part is probably for the immediate stimulation, immediate maturation. Lateral part is for the storage and the later maturation. Then next one, lateral facilitate the storage. Then below that, just above that, midbrain center. Midbrain center just above that, there is a periaqueductal grey matter. Aqueductal grey matter that inhibits the grey matter, and the circulation is mostly found in between the PAG, PMC circuits. Those are the circuits. Periaqueducal grey matter and the pontine maturation center. Circuits are mostly happening there. Next one. Then last the cortical center, prefrontal lobe, anterior cingulate lobe, insula, and the insula is inside the sylvian fissure and the sylvian sulcus, and the voluntary decision to permit or delay maturation. So the layers of control, multiple layers of control. So this is the, this is the S234 area, this is the sympathetic area, let us say. This is the pontine maturation center, medial center as well as the lateral center, and the periaqueductal gray matter, that is along the center of the aqueductus you get the periaqueductal center and also the higher cortex. So let us say what, and this is the bladder, and this is the internal sphincter, this is the external sphincter. So as the bladder is extended, what happens? From the A delta fibers, signals get inside and go to the periaqueductal gray matter. It doesn't report to the brain, and that is going and storing in the lateral part to say that hold on, no need to worry, it's only 40 ml, we can wait until the class is over, like that. So it is go there, and then from there next is distended. Some more time the C fibers are activated. So volume mass is 500 ml. So it goes to the through the periaqueductal gray matter, ventral, posterolateral nucleus of thalamus, C fiber, the pain pathway, sphenothalamic pathway. It goes there and goes to the actually it's supposed to go to opposite side. I will show it on the same side only, to the cortex. Then what happens? Along with any C fiber activity, there is also a stimulation of the thoracolumbar column. There is a basis of autonomic dysreflexia. Any pain that goes up stimulates the autonomic pathway, and if that is under control, you get the vasomotor, pseudomotor, pilomotor responses getting up in autonomic hyperreflexia. So as it goes on, there is a stimulation of the thoracolumbar column T10 levels. So what does that do? That has got a short preganglionic fiber and a long postganglionic fiber. That is the nature of the sympathetic fiber, short ganglion. From the ganglionic cells, the postganglionic fibers are long and comes here, and what does it do? It inhibits the detrusor here, so the storage is permitted, and it tightens the internal sphincter. So storage is permitted. Next one. So then you decide to maturate or not maturate. What happens? The cortex reports to it periaqueductal matter and goes to the medial Barrington nucleus, medial pontine maturation center, and from there is direct connection. Pontine maturation center, there is direct axonal continuity to the sacral parasympathetic nucleus. Direct axonal, just like the cortical spinal tract, there is a direct axonal continuity to the sacral maturation center. And sacral, we have, they have got both the parasympathetic as well as the somatic cells now. So what does it do? It, let us say this is the parasympathetic nuclei activated. What happens? It has got a shorter postganglionic fiber, long preganglionic. Parasympathetic system is long preganglionic and a short postganglionic fiber. So and they activate the detrusor. When they activate the detrusor, what happens? Next one. There is also an inhibition of the on-off nucleus. On-off nucleus is inhibited. On-off nucleus means it's a name of a person, but it is a, you can say as on-off sort of situation. But it is a nucleus that controls the bowel sphincter and the bladder sphincter. That inhibits the sphincter. So then what happens? Detrusor contracts, internal sphincter relaxed, and in the storage phase, the same thing is going to be repeated. Now you can work it out. A delta fibers going to the lateral part, and then storage. Then comes C fiber. Bladder has distended now. It goes to the reports to the cortex, and the cortex, what does it do? It decides to store, and also there is a sympathetic activity. What it helps in relaxing here and increasing the tone here. Then and decides to the lateral periaqueductal gray matter to the pontine maturation center. It inhibits the medial maturation center. There is inhibition there, and then when there is inhibition there, what happens? The retrocessor is also inhibited, relaxation, and it stimulates directly the on-off nucleus, and there is stimulation here to hold on the urine. Is it rough idea clear? So this is the baseline pathway of the bladder, which helps us to manage various situations. So this will be in the management of the sacral cord, thoracolumbar cord, pontine infarcts, cortical injuries. So bladder behavior in different situations. Next one. So now we are going to with the management part of it. Spinal cord injury, what happens? There is a area of damage. This part is all okay. Pontine maturation center, periaqueductal gray matter, cortex, all is okay. Sacral centers are all right. But there is an interruption between in either direction. Mandas Basher, many of you would have met him, and he came here. He came and helped us in the workshop on the bladder. His classification is the easiest classification, easy to follow. Neutropathic bladder, where when the bladder is denervated, the retrocessor becomes spastic, hyperreflexic, and then what happens? Sometimes the sphincter, skeletal sphincter, not the internal sphincter, skeletal sphincter also becomes hyperreflexic. So when the pressure is raised in the bladder, what will happen? Some urine will come across the retrocessor, and some will go back into the kidneys, producing renal damage. Another combination may be a hyperreflexic bladder and a weak sphincter. What is the result? It will be constantly dribbling because this constant contraction of the hyperreflexic bladder across a weak sphincter. Third will be where there is a spastic, tight, hyperreflexic external sphincter and a very relaxed bladder. So that means our original goal was what? Our original goal is low pressure storage that is being offered by a hyperreflexic retrocessor, and a continence which is offered by a closed sphincter. And during the retrocessor, when in another situation where, for example, cauda equina, where both nerves are gone, there will be a hyporeflexic bladder and a hyporeflexic or open bladder neck. So what will happen? There will be some retention and overflow all the time. When you cough, it's open or coming out. The pressures are only from the external pressures. The retrocessor itself is not able to generate a pressure, and the sphincter is not able to hold, if at all any pressure is able to, it is encountering any pressure. Next one. So initial bladder management in the spinal shock. What do you do? In the spinal shock, the bladder is, what is the definition of spinal shock? Isolated spinal segment devoid of reflexes. So in the spinal shock, bladder is acontractile. So what happens is like in the initial situation, there is acute retention of the bladder. So again, low pressure storage, so indwelling catheter, provide drainage and prevent infection, and see whether the adequate input is adequate. Next one. Common drainage method will be used by patients after the acute later will be what? It can be indwelling catheter per abdomen or through the urethra, or maybe pressure from the bladder, or suprapubic pressure, or by intermittent catheterization. We will find out the complications of all this and then manage like that. Advantage of clean intermittent catheterization is it is a clean and a non-sterile clean non-sterile technique. We discussed the rule of Lapidus. You heard about him, all of you? You would have heard everybody. Yes, we had a discussion about him, about this during the social meeting last time. With Guru and all there was a talk, no? So essentially this is a patient. He learned this Lapidus as a urologist who learned this method from a patient. Till then, Ludwig Guttmann, who was the father of rehabilitation of spinal cord injuries, the teaching and everything was that because of the bacteria, infection and all that, it has to be a sterile catheterization. You have to wear the water, antiseptics and all those things. So he taught our Lapidus also taught it to a patient with a lady with multiple sclerosis who has got a bladder problem. So she taught her how to do all these things. And she went on a tour somewhere. When she went to the tour, and she was in the washroom, and she was all getting ready for all that, and down it falls, the catheter falls into the ground. So what to do? You are in some foreign country, no place, nobody to call and help and all that. So she what to do? She took it and washed it and used the catheter. And she thought something is going to happen. Nothing happened. So later on, she went and spoke about this to the doctor. But the doctor, what will you do if you were the doctor? You would have been very cross with the patient, saying that you are doing something very dangerous and all that. But he understood that maybe this extreme sterility is not required. Only cleanliness is required. So the clean catheterization, the clean and non-sterile, the urine also may have some bacteria there. So it is not a urinary infection, but it will be just some colonization. Just like in the mouth, if you culture the saliva, you will get hundreds of bacteria, but you don't take antibiotics for that. Because by the time before the bladder, the number of bacteria become critical, you are going to drain it in a 4 hours time. That is why that strict, disciplined 4 hour or 6 hour duration, as well as cleanliness is required. Should be compliant. That is what compliant means, that water intake and the bladder catheterization. Professor D.G. Thomas from UK, he came here. So when he talked about his urologist to help us in setting up the neuropathic, the CMG machine and all that. And when he was asked about the ICC, he said, only one word I have to tell you: discipline, discipline and discipline. So discipline in hand hygiene, discipline in fluid management, discipline in the overall bladder management. Outlet resistance, there has to be sufficient outlet resistance. There has to be sufficient. Even if the outlet is open, then the water may keep on leaking, or urine may keep on leaking. And when the patient is hemodynamically stable, he is able to sit up, and all the fluid shifts are all settled, and there should not be any sensation. If there is a catheter, the urethra is a highly sensitive area, and it has to be pain-free catheterized. Otherwise, if it is painful, compliance is, you can't expect a compliance. And hand function should be adequate. Next one. So restrict the fluid intake, not to unphysiological levels. So don't reduce it to the obligatory that level. If it is a little more, they may get a leak. Other than that, nothing may happen. So modest reduction of fluid intake, 4 to 6 hourly catheterization, and use and soap and water, no disinfectants, and catheter. Any of these catheters can be used, and a jelly, preferably with some local anesthetic, so that any afferents can be reduced. Patient education and treat infection and not the bacteria, not bacteriuria. So if you culture any urine with intermittent foreign body going in and out, there will be some bacteria. So you see the various complications that you see when you go to the ward with the patient. There will be epidermal. As soon as they present with fever, we look: is it epidermolysis, is it abscess, is it diverticulum, is it fistula, calculi, blockade, hydronephritis, ureteric calcification, high residue, all sorts of problems. These are much less in the much lesser in the much less in the CIC, but you see, in indwelling catheter, epidermal orchitis is common. Periurethral abscess, you would have seen so many cases, because the normal ducts that drain the urethra are now getting occluded by the foreign body that is kept in the urethra. Then urethral diverticulum, fistula, pinoscrotal fistulas are quite common. What is it due to? The basis of strapping the catheter onto the abdomen. The necessity to transfer the prostate is there, or maybe not, and then urethra is like that, isn't it? Shall I remove it? Oh, how easy. Why didn't you tell all this before? Riju, Piyush, making me. No? No. Urethra comes down, and then it goes onto the anterior wall. Umbilicus is there, and then urethra is there, testis, and goes into the peritoneum. So this angle, so when the indwelling catheter is there, what happens? The foreign body is there, and the catheter goes like that. Now I know what to do. So that plus you put connected to a bag of urine. So 1 liter urine is falling there. What will be the weight? 1 kilo. Is it not so? How will it be if you put 1 kilo into the urethra and walk around? So what will happen? The necrosis happens in the testis is here. Penoscrotal, the skin will disappear. Is it not so? And you see lots of cases, you would have seen managed a lot of cases too. Then of course you have to put SPC, divert the urine, reduce the fistula and all those sort of things. So simple things. So that is why what we do is in the management, one thing that we do is we try to strap the catheter upwards, so that the urethra as well as the catheter is now strapped onto the abdomen. So the chances of this angle now becomes straighter. This whatever is downwards is now becoming straighter. So the skin is now intact. So very simple solution to prevent a very difficult complication. So when the patient is on a catheter, you can imagine the number of complications. Creeds. What happened? Again, when you raise the pressure, there will always be residual urine. So calculi is more. Catheter related complications are less there. On account of the catheter, those are less. But you see, calculi, upper tract changes. The pressure that you put mechanically with your hand, some of the pressure may be successful in bringing out some urine, but the pressure that the ureterovesical region and the backward pressure produces ureteric dilatation and high residual urine and renal complications and failure. Intermittent catheterization, of course, if it's not very careful, you may get a epidermorchitis, calculi, if it is not a lot of storage time, and false passage and stricture because there is no sensation. Next one. Pharmacotherapy for the bladder. So you know all these things. There are though acetylcholine is the mediator, the receptors are muscarinic receptors. So muscarinic receptors. For instance, skeletal muscle got the nicotinic receptors. Muscarinic receptors also divided into M1, M2 and M2, M3 and selective receptors, selective management like that. So cholinergic muscarinic receptors. Then in the sympathetic pathway got the alpha receptors and for the sphincter and beta receptors for the retrosor part. Then purinergic receptors, vanilloid receptors for the C fiber vanilloid receptors. That's a study that was started initially, which ended up getting that machine, that capsaicin to block the afferent arm of the sacral reflex. You block the afferent arm, there is no improving the storage. Next one. So drugs. What are the drugs? One is to reduce the detrusor hyperreflexia. So what will you use? You use some anticholinergic medicine so that the acetylcholine is blocked. Anticholinergic drugs or botulinum toxin also. Though it is on a smooth muscle, because the mediator is acetylcholine, we can successfully use in some other use application. Non-skeletal muscle application of Botox will be even hyperhidrosis, mediated by the sympathetic cholinergic fibers, like that. So the common drugs used are propandolene, oxybutynine, tolterodine, sodifenacin. Even transdermal is not available, and now newer medicines are available for more and more selective. Listen. The is abandoned. But it's a wider blockage, so therefore adverse effects are more. Long-term effects of on cognition, memory, those are all dementia. All those are being proposed because they are using so many years. So for memory, cholinergic pathway is very essential. So when that is blocked, memory problem has been proposed there. Then reduce hyperreflexia by blocking the motor arm or by sensory arm. Sensory arm is one by the capsaicin, and also another method is by the neuromodulation. We'll talk about that later, how to modify the afferent arm. Then smooth muscle inhibition. Then now is the bladder neck to improve the emptying. Modify the modify the bladder outlet resistance. How do? You can sympathomimetics. These medicines are good, but again not that very effective. Partially helpful because adverse effects are also there, because the receptors are there everywhere, not just on the bladder neck. So there will be some adverse effects of that also. So you want to modify, if you want to open out the bladder neck, you can use the alpha blockers like terazosin, prazosin, doxazosin. All that will open out the sphincter so that the emptying will be better. So you have to adjust according to the problems and the findings that you see. Yes, sir. How do you monitor? These are the medicines available, pharmacotherapy available there, and how do you measure? How do you monitor? Monitor is because first of all, even in normal situation also, kidney symptoms are very silent, unless it is a stone or something. Sometimes transiently you may see the creatinine is 3, 4 like that. We may not even know. So upper tracts will be look at the ultrasound, post void residual urine, hydronephrosis. The fluid is not flowing across into the bladder. The ureter is getting into the retroseptum at a particular angle, as well as there is a lot of muscles there. So you have to see whether hydronephrosis is there. So lower tract, how do you see? Can you also by visually seeing it by cystoscopic method and look at the urethral complications. And high pressure, what is the pressure? You are always worried about the pressure in the bladder. That is by seeing the urodynamic pressure changes. Then monitor the infections. So what do? You look at the urine analysis will tell you about the protein or infection and all that. Frequency, volume chart, bladder diary. Though it is a simple thing, we'll keep on asking what is the diary, how much volume you took, when was it leaking, is it just before ICC, is it after ICC, all sorts of things. If it is infection, then of course culture sensitivity. So the urine analysis will tell us most of the things. If there is something doubt on that, then go into culture sensitivity if you think it is still an infection. Ultrasound of the bladder, kidney. So all these are what you are doing. And the creatinine value. So this all you are familiar day-to-day, your day-to-day work. Dilated tracts, open neck, diverticula, diverticulae, then trabeculations, all this you see every day. Cystometry. Next one. The parameters measured are the leak frequencies, leak volumes, maximum ICC volume. They will tell us approximately the bladder capacity, how much is the bladder can hold. Leak volume, and when does it happen? Cystometry will tell us the reflex volume. When did the first bladder contraction appear? And then also we will see the leak point pressure. At some particular point, the bladder has leaked. When it leaks, of course, the pressure will drop because the water has come out. And the leak point, what is the leak point pressure? Then capacity of the bladder. This you are familiar, it's everyday work. Where at 180 ml you get the reflex volume, maximum pressure, leak point pressure, and also you see the what is this one? EMG of the perineal muscles. What do we actually want? We want the EMG of the external sphincter. Is it not so? We want to see whether the external sphincter is dysenergic. When the bladder is contracting, is the sphincter also contracting simultaneously? We know the normal supply, the retrosa contracts. Through the inhibition, it has to be relaxed. Then only the smooth maturation can happen. So, but it's very difficult, not difficult, but again it is more invasive to put a needle into the external sphincter and then record the maturation. Instead of that, this will be a surrogate marker, because all this has motor efferent arm is the pudendal nerve. The pudendal nerve, one branch is supplying the external sphincter, another branch is supplying the perineal ischiocavernosus and all the perineal muscles, and the of course the sphincters. So this will be a surrogate marker. So if this is contracting, you will know that it is contracting. Is it contracting when the detrusor is contracting? Is this also contracting simultaneously? Is there a detrusor sphincter dyssynergia? Like that. And now comes we talked about the management. This is the portable cystometry CNG machine devised by our rehab engineering under I was privileged to be the guide of Dr. Rajdeep, and also I was the guide for Bobina also. So nice, happy that both of you are here now. So the large machine that you saw, 3-4 hole, which is occupying the whole lab, now he has made it into a very small device, and I think now it has become even smaller. You can carry in the pocket. Yes. So it becomes a wireless, portable. You can see the ambulatory urodynamics, just like the ambulatory halter you see, and the ambulatory urodynamics like that. So this is we did along to see the CMG from the commercial machine, and parallel port we put on the same catheter to the machine from the CMC data acquisition system, and we found that the waves are exactly similar. So you see the fluid chamber, then the counter, drop counter, infusion pump, pressure sensor, preamplifier, and the sensor. So I think this has changed. This was an earlier version, like the car Mark 1, Mark 2, Mark 3. New Mark are going to come. This was about a few years ago that I have done. Then the surveillance pattern. So there was a conference in 2003 in the management of the bladder. 160 urologists from United States. They thought what is required is, in this situation is, there is yearly ultrasound and lower tracts if there is a problem to monitor lower urinary tract. That was their consensus. That is what we are doing. We are doing the yearly ultrasound or sound and the urinary tract, lower urinary complication monitoring if we are clinically expecting any problems. Most accepted management is hyperreflexic bladder. Okay. Give anticholinergics to convert the hyperreflexic detrusor into a hyporeflexive bladder, and then drain it. Continence is provided by the timely cell voiding. Reflexive bladder only the transition. Next one. What to do and when? So then, in as an example, this one, spastic bladder. Classification number 1. When both are spastic, what do? Add anticholinergics to provide the sphincter, and the spastic provider, don't do anything with that. Let it be there. It will provide the sphincter, and just do the emptying. This is all made by Bladder Basher. Just spastic bladder with the spastic sphincter. Start ICC. Don't do anything there. Flaccid detrusor. Flaccid detrusor with a spastic sphincter. So this is nothing to do, because it's as though the detrusor has been weak. The pressure provides a low storage, and start ICC. Don't do anything more. There's a flaccid detrusor with a flaccid sphincter. You can ask to see whether you can improve the smooth muscle alpha agonist to increase the tone here, and see whether that may improve a little bit, and then provide the continence by intermittent catheterization. So when you add the alpha agonist, this sphincter tone may improve to provide the storage. This situation is very difficult. That is, you may find all this is in general, not in every situation. In general, you may find all that. Because the bladder is spastic, the sphincter is weak, constantly dribbling, and add anticholinergics to reduce the sphincter here, so that it can prevent the upper complications, and then start ICC there. They are trying to anticholinergics to reduce the tone here, and alpha agonist to increase the tone on the smooth muscle sphincter. All this tone we are changing. We are talking about the smooth muscle. Western sphincter we cannot do these sort of things. Western sphincter, the most what you can do is very spastic or something. Botox you can inject to relax the sphincter. But as a chemical thing, when we are saying tone, sphincter increase the tone, reduce the tone, we are talking about the smooth muscle sphincter through the alpha and beta receptors, which are mediated by the sympathetic pathways. Surgical modalities. One is sacral anterior root stimulators. Sacral anterior stimulator, you know the circle of pathway, afferent is there, center is there, deferent is there. So the hyperreflexic bladder, for what is a reflex? Reflex should have a afferent arm, a center and an efferent arm. So you remove the cut the posterior root, that becomes areflexic posterior root, and in the anterior root you put a stimulator for voluntary maturation. Second is artificial. So now instead of ablative procedures, there are parallelly stimulating the posterior root with the different frequencies, so that the upper there is modulation of the sacral center. We will talk about the modulation soon. Then this is a mechanical thing. Artificial urinary sphincter means, just can you take in? Go back here. Back of the. Then come back. Board, black, pen, white. So sacral anterior root stimulator means what happens is there again the same similar situation where what happens here? So what happens? The bladder becomes spastic bladder. You want to reduce the bladder, spastic bladder, or maybe spastic sphincter, who knows, like that. So the afferents are going. There may be spinal cord injury, but afferents are going. When the sacral anterior stimulator, what happens? SARS, sacral anterior root stimulator. Previously it was controlled with dorsal rhizotomies. Dorsal rhizotomy was the original thing, or dorsal rhizotomy or dorsal root stimulation. So now the procedure is dorsal root stimulation. So once this is ablated, this part is blocked, this part is the conduction is blocked, then the bladder becomes areflexic because the arc is now discontinuous. Then you put on the root, spinal root, a stimulator which is controlled from inside, neuroprosthesis stimulator from inside, and then maturate at on stimulation. So these stimulators they usually use one for maturation, and another route you can use for the bowel sphincter, so the bowel continence, and also to stimulate the sexual function in males. So multiple possibilities are there. Artificial urinary sphincter means where artificial urinary sphincter is just a device where you put a additional bag, like inflatable bag. Inflatable bag is there around the urethra. That has got a small connection, and that is a rigid bag, a rigid tube, all placed internally, and there is a reservoir. That reservoir is placed either on the scrotum or on the labia there. So the principle is that there is the fluid filled into all this. Fluid, is not so. At rest, because of there is a differential tension on these bags. So at rest, what happens is the fluid will remain in around the urethra. So when you want to maturate or reduce the bladder neck pressure, you have to squeeze the bulb. It's not so. When you squeeze the bulb, there is a valve or something, the fluid comes out of into the reservoir. When it comes into the reservoir, then you can do the SIC. Then as soon as you leave it there, the differential pressure again makes it sure that this collapses, pushing the fluid back into the periurethral. So it's the artificial urinary sphincter. So it can be useful in, there is no neurological stimulatory mechanism, not a neural process, it's like a mechanical device, as an artificial urinary sphincter. Mitrophenol, you know, mitrophenol is using the appendix as the bladder. Appendix as the bladder. The long smooth muscle conduit is there that is connected to the dorsum, and you can do the catheterization. The anti-gravity position itself gives the continence, and then you can catheterize whenever required. Then of course the bladder is very tight. Sphincterotomy or Botox injections will be useful for skeletal muscle tone. Strategy changes. When do you change the strategy? And you see a patient with dilated upper tracts. So immediately what you do, you have to drain the bladder. So you reduce the pressure. So a short-term indwelling catheter, adequate hydration till creatinine comes to around 2. When it becomes less than 2, then start ICC and anticholinergic so that the pressure is maintained. Next one is pyelonephritis. Again, patient with CAC, has develops a stone, comes with a urinary tract infection, then revert to again short-term IDC so that the bacterial count inside the body is less. Whatever bacteria is there immediately comes out of the body. There's no abscesses there. And adequate hydration, appropriate antibiotic and anticholinergic. So anticholinergics become a major player in the reducing the bladder tone. Additional modalities are Botox into the retrocer to reduce the tone, because there is acetylcholine is the mediator there. And instead of sphincterotomy, Botox to the external sphincter is required, and neuromodulation with functional electrical stimulation. So the Botox retrocer is given to the, we have also a syringe, through that we can inject about 200-300 units at multiple sites as required. Infection is a major problem we have to be careful about. And retrocer sphincter dysenergy is wherever the retrocer is vesicle, P retrocer and this EMG, and you see that there is always a contraction, concurrent contraction. So what was done? This is the I think Henry did this in this case. So injecting into the retrocer, intravesical Botox. This was the unique novel thing that Raj did, where you stimulate the posterior tibial nerve. Which are the nerves from the sacrum that comes out, which we can reach out, because pudendal, as you said, the word itself is secret and is situated deep. But again, dorsal penile nerve or dorsal clitoral nerve, and all comes out. There you can get the sacral nerve, and also the sacral segment nerves, or maybe the posterior tibial nerve, or the even the cutaneous sural nerve distribution there on the sole. All this can produce. You have a pathway, a window into the denervated sacral segment. Sacral segment, which is isolated from the higher centers, is now there is some way to communicate with them. So therefore, we send some particular frequency of electrical stimulation to the posterior tibial nerve or onto the dorsal penile nerve. These are the nerves that we had done, and then see how what happens to the tone of the bladder. This is the same principle as I told in the SARS. Instead of dorsal rhizotomy, dorsal root stimulation is used to, because the dorsal root, just like the TENS, when that low pressure, low A delta, fast traveling A delta fiber is kept on stimulated by the transcutaneous nerve stimulation, what happens? The pain fiber is not able to travel, and therefore the pain is blocked. The gate control theory by Melsack and Wall. And whereas this one, similarly, we are trying to continuously stimulate the dorsal root so that the maybe the afferents are coming reduced because this signal is busy going inside there, or maybe the segment itself is getting through the various inhibitory pathways. So what you see is that, see, this is the patient, the bladder pressure volume. Bladder pressure volume. See, the reflex volume is reflex volume is very at a low volume, is getting a high pressure there, whereas now the CMG pressure is, the duration has increased, the pressure is, it's about 15 day 15 of CMG after day 15, on the day of starting, and you can go to the details of this by his publication there. This we did initially. Why did we do the FY in a CMG? This EMG study on the same patient, because we wanted to know whether it is a chord equivalent lesion. There is no way to know whether the fibers are getting into the cord, the afferents are getting into the cord. The F wave at a supramaximal stimulus, what will you do? It produces an F wave. So that is the basis of the, even the F stands for foot wave. That is the original description, foot wave. So whether this is going to the spinal cord, we want to know. So you set the supra-maximal stimulus from the tibial nerve, so you get back a F wave. So you know that it has gone into the posterior root, it has gone through the anterior horn cell, and then it has gone. Supramaximal stimulus doesn't go through the posterior root. Supramaximal stimulus goes to the anterior root itself. It also goes there and stimulates the anterior horn cell and then comes back. So the integrity is being checked. So in summary, here is a summary. Summary is non-operative management is the mainstay. People may come and ask, do an operation, make me continent. Mainstay is non-operative management. Discrete management and triggered voiding, that stimulate in the groin, stimulate in the inner thigh, stimulate in the other similar innervated structures, are all unsafe because it doesn't result in a complete emptying. There will be residual urine, residual volume, and then infection and all the complications that are enlisted. It will catch up with them at one point of time or the other. Long-term IDC, from the list of complications, you know that long-term indwelling catheter is not a, long-term foreign body is not a thing to be encouraged. And tetraplegics, because where you said one of the conditions was CAC was a fairly good hand function, fairly good sitting balance. So these are probably compromised in patients with high spinal cord injuries. Therefore, SPC, a continuous drainage, will be preserved for the drainage for the bladder, and the genitalia is free for the sexual exploration functions and various things also, and the urethral complications can be avoided and doesn't have to have a additional help for a intermittent catheterization. So there will be little more freedom there. CIC and bladder relaxants are the method of choice. And asymptomatic bacteria, if you see a bacteria, if you encounter bacteria in the bladder, unless there is infection, just keep quiet. This is the final thing by Windale as well as Mader Basher. Okay.